First of all, I would like to thank the organizing committee, especially Dr. Bikal, for giving me this opportunity. The topic given to me is neoadjuvant and adjuvant treatment in colorectal cancer. When I see this topic, my first reaction was, Bikal wants to cover me two topics at the same time. And I will tell you what. The two topics would be adjuvant therapy in colon cancer and neoadjuvant therapy in rectal cancer. Because we must have all seen this picture. It seems the colon and rectum are similar structure, behaving similarly, and management is not that different. But that's not at all true. So for all practical purposes, there may be anatomical differentiation, there will be surgical differentiation. For all practical purposes, for the treatment, especially the oncology management, cancer 12 cm from anal verge is considered as rectal cancer, and any cancer above that is managed as the colon cancer. So for oncologists, colon is basically a systemic problem because it can be well mobilized. Adequate margin can be taken. Lymph node dissection is relatively easy. So what all this does is we have excellent control with surgery alone. So whenever it fails, it usually fails systematically, that too in liver. So colon is basically for oncology a systemic problem, whereas rectum is a different entity. Here the organ is confined to bony pelvis, so it's difficult to dissect. It has close proximity to pelvic organs. Lymph node dissection is harder. And as you go distally, the peritoneum covering is scanty, so the local infiltration is early. So what all this leads to is high chances of local failure. So we have to discuss it very differently. So first we'll talk about the adjuvant therapy in colon cancer. So what we need by adjuvant is there is some other primary treatment, and in this case is a surgery. Then we add something to increase the survival or local control. So whenever we talk of adjuvant, it's always for curative purpose. So whenever we talk of adjuvant therapy, first question we have to answer is, what if we don't give anything? What are the results? So we have to see the historical result. So if we see the historical result of colon cancer with surgery alone, the local failure is around 6%, and the abdominal and intestinal failure is around 15%. And if you see stage-wise, for T1, T2, N0, the 5-year survival is excellent with surgery alone. So this patient do not require any adjuvant treatment. For N+, NE3, N+, or T4, N0, it ranges from 38 to 74%. So these are the patients which requires adjuvant treatment, and T3, N0 is in the gray area. So what is the basis of adjuvant therapy in colon cancer is, despite curative surgery, many patients suffer tumor recurrence, leading to cancer-related death. So there is need of adjuvant therapy to increase disease-free survival and overall survival. So in high-risk patients, as we have seen in previous slide, T3, T4, and N+, we need some form of adjuvant therapy. And since systemic recurrence is the problem, we will talk more about chemotherapy in colon cancer. So this is how chemotherapy has been developed in colon cancer. 90 were the first introduced trial which shows addition of chemotherapy leads to better survival. And the last major improvement was made in 2011 when capecitabine became the standard of care. So first trial which shows addition of chemotherapy to surgery increased survival was introduced 0035. Here levamisole was used, and if you see disease-free survival, in stage 3 patient, the disease-free survival increases from 44 to 61%, and in stage 2, the survival difference was not that much. So the QUASAR trial is a very important trial. I won't go through many trials. I will just say the trials which are the milestone in the treatment. So in QUASAR trial, among other things, the most important thing was the treatment duration, because before that many treatment durations were used. Some used 24 weeks, some 1 year, some 6 months. So here in QUASAR trial, the 24 weeks treatment has the best result. So since the QUASAR trial, the standard of treatment in colon cancer is 24 weeks of adjuvant treatment. No matter which regimen you use, the standard is 24 weeks of adjuvant treatment. Then comes the MOSAIC trial. This is a very important trial. Here the standard 5-free leucovorin, oxaliplatin was added, which we commonly call FOLFOX regimen. And with FOLFOX regimen, the 3-year disease-free survival in stage 3 was improved from 66 to 72%. However, the difference was not much in stage 2 patients. However, one thing to note is oxaliplatin is very neurotoxic. So if you see the neuropathy, it's very high. So the difference in stage 3 is enough to accept this toxicity. However, in stage 2, there are still doubts. So another pooled analysis from 7 trials with 3,300 patients. So here both stage 2 and stage 3 tumors were involved. So the result was that significant stage by treatment induction was present, showing significant benefit for stage 3, but not that for stage 2. So these initial results show that maybe in stage 2 patients we may not give chemotherapy. However, this was the trial which says that it was published in Journal of Gastrointestinal Surgery in 2012, where it's a systematic meta-analysis. In 12 RCTs were used, and it only sees the role of adjuvant therapy in stage 2 patients. So 5-year overall survival favors adjuvant therapy, 5-year DFS also favors adjuvant chemotherapy, and there was significant reduction in risks of recurrence favoring adjuvant chemotherapy. So these are contradicting data. Some showing that even in stage 2 there is significant advantage of chemotherapy, and some saying there is no significant advantage with stage 2 patient. So stage 2 is not a homogeneous disease. So there must be some subgroup where chemotherapy had advantage and some subgroup where chemotherapy has no advantage. So different subgroup analyses were done, and the results were that in stage 2 patients, if it's PT4, grade 3 or 4, LVI positive, PNI positive, less than 12 lymph node examined, that is inadequate lymph node dissection, intermediate closed or positive margin, and if patient present with obstruction or perforation, these are the high-risk stage 2 patient and they should be given chemotherapy. Whereas if any of these are not present, the patient chemotherapy can be avoided in such patients. So since then FOLFOX has become standard, then there comes the oral form of 5-FU, that is capecitabine. It's easy to give, the patient compliance is very high. So there were trials that if capecitabine is equivalent to 5-FU, and one of these important one is Sol et al. So here the capecitabine and oxaliplatin, that is capeoxyregimen, was combined with traditional 5-FU leucovorin, and the result was excellent, that capeox increased 7-year DFS from 56 to 63% and 7-year OS from 67 to 74%. So after this and few other trials, the capeox was also formed the standard treatment. So another is how long to give chemotherapy. So as I have already said, QUASAR gave the standard that 24 weeks is the standard. But this very interesting article published this year in NEGM. So here it's a meta-analysis. Here 12,834 patients were evaluated, and here the author want to see if the 12 weeks treatment is equivalent to 24 weeks. And in conclusion, he said that in low risk stage 3 patient, that is T1, T2, N1 patient, 12 weeks is equivalent to 24 weeks in this subgroup of patients. So in this subgroup, maybe we may use the short form, that is 12 weeks treatment. So we have to wait for more trials to confirm that, but this is very interesting buzz in oncology right now. So another important is timing of adjuvant therapy, because sometimes the patient gets discharged early, sometimes they have some complications, so they have to wait to get discharged early, sometimes one infection, delay the recovery. So actually what's the best timing for the adjuvant therapy? So in this meta-analysis, it shows that each 4-week delay in giving chemotherapy results in 14% decrease in overall survival. So in another retrospective analysis, it shows that if the chemotherapy is delayed beyond 6 weeks, there is significant decrease in disease-free survival. So the bottom line is start chemotherapy as soon as patient is physically fit. That usually occurs in 3 to 4 weeks, but do not delay it beyond 8 weeks. So is the role of radiotherapy? So to see role of radiotherapy in post-operative patient, where do you give radiotherapy? Because the tumor is already gone. So it's usually a tumor bed. That's where the tumor was present pre-operatively. But in colon, if you see the yellow are the mobile part, that is intraperitoneal part. So here there is no tumor board because it's an intraperitoneal, it's a mobile thing, so there are no tumor board. So in this area, especially transverse colon, cecum, and proximal sigmoid, there is no role of radiotherapy because there is no tumor bed. However, the retroperitoneal part of colon, that is ascending and descending colon, they are more or less fixed. So in this patient, maybe there is a role of radiotherapy. However, these were the trial where chemotherapy was compared with chemo and radiotherapy. So it did not show any significant advantage in adding radiotherapy, but it increases toxicity. So routine use of radiotherapy in colon cancer is not used. However, there are some patients where the local recurrence is very high, especially the patient with CIN positive in ascending and descending colon, or tumor infiltrating retroperitoneal structure like psoas preoperatively, or ascending or descending tumor presenting with perforation and fistula. These are the tumors where local recurrence is very high. So these are the tumors where radiotherapy can be added. So is the role of neoadjuvant chemotherapy. So these were the trial where neoadjuvant chemotherapy was tried. However, there was significant downstaging but no change in PFS and OS. So there is no routine role of neoadjuvant chemotherapy in colon cancer. However, it can also be given in some subgroup of patients, especially in locally advanced, that is T4B, not resectable initially or difficult to resect, or unresectable metastatic liver disease. So, to conclude, in T1, T2, N0, M0, there is no role of any adjuvant therapy. In T3, N0, low risk, there is no role of adjuvant therapy. In T3, N0, M0, high risk. Here, 5-leucovorin or capecitabine is the standard adjuvant treatment. Addition of oxaliplatin doesn't add much, but increase toxicity. However, in T4 and N+, Folfox, Capiox, or Flox is the standard treatment. So now coming to the rectum, we have already said this is the surgical series of rectum, and if you see the local recurrence pattern, it's very high, from 24% to 46% after surgery alone. So if you see the site of recurrence, it's usually limited within the bony pelvis. So these are the areas which can be easily covered by radiotherapy. So radiotherapy has been used from initial time as an adjuvant treatment to rectum. So if you see after the addition of radiotherapy, the local recurrence decreased from 5 to 15%. So as there is progression in surgery, total mesorectal excision becomes the standard of care, and there has been some thoughts that maybe after TME the local recurrence is so low that we don't need radiotherapy. So these are the results of TME, which says local recurrence around 7 to 10%, and overall survival from 66 to 80%. So these were the very important DOS TME trial. It was a prospective randomized trial where 1861 patients were randomized to get surgery alone or surgery plus TME. So here pre-op radiotherapy was used, and 2-year overall survival was not different. However, 2-year local recurrence rate was significantly different. That was 8.2% for TME alone and 2.4% for RT plus TME. After the DOS TME trial, I think the debate was settled and radiotherapy has been the standard adjuvant treatment. So another important question to answer is pre-op RT or post-op RT. So advantage of pre-op RT is that it causes the downstaging, and which may reduce the tumor volume, thus increase chance of sphincter precipitation. In pre-op RT, tumor is well oxygenated, and radiotherapy works well on well oxygenated tumor. So maybe the chances of downstaging more. And the most important, as a radiation oncologist, if you ask me why you want to do pre-op RT, because in post-op patient, the small bowel comes down and it gets very high dose of radiation. So radiation enteritis is very difficult complication. They say if you manage one radiation enteritis in your life, you will never forget it. So this is very important, that in pre-op RT, the chances of radiation enteritis is very low compared to post-op RT. And irradiation, when the pre-op RT is done, the irradiating tissue is removed during surgery, and the remaining is a healthy tissue. That's also important. But there are some few disadvantages. One is over-treatment of early stage, because we know in T1, T2 rectal cancer, we don't need any adjuvant therapy. So this may be the tumor which may actually get treatment, which may not require. And another is exact pathology is lost, because we have given pre-op RT. So what was the exact pathology? Now the molecular classification and coming on and on. So exact pathology is lost. These are the disadvantages. So the only randomized trial which compared pre and post-op RT was conducted in Sweden. Here the pre-op RT decreases the local recurrence from 22% to 33% and reduced grade 3 toxicity occurred with pre-op radiation from 41 to 20%. However, there was no difference in 5-year survival. So these are the trials with pre-op RT, and most of the trials were decrease in local recurrence, but only Swedish rectal cancer trial is the one with survival advantage. So since this trial, pre-op radiation has been the standard in rectum. So another question is, will addition of chemotherapy help? We have been talking about only the local control, but in the advanced disease, especially T3, T4 and node positive, there are high rates of local relapse, around 50%, but also the distant mix, that's 24 to 35%. So the objective is increase the sphincter preservation, increase local control, and increase overall survival. So these were the trial of the post-op RT. Important is one, or maybe the upper two one, which was the addition of chemotherapy to radiotherapy decreases the local recurrence from 58 to 46%, from 24 to 11%, and 25 to 13.5%. So another thing we always talk when we talk pre-op radiation is sphincter. We can preserve sphincter, we can increase colostomy-free survival, patient don't have to do colostomy. So these are the trials which especially look on the sphincter sparing. So here the surgeon will ask if this patient requires APR before giving any form of therapy. And these are the number by surgeon they thought they need APR. However, post pre-op chemo RT, there is sphincter preservation from 44% to 78% in those patients who initially were thought by surgeon to require APR. So a sphincter sparing approach accomplished in 23 to 85% of patients, and local control range from 83 to 100%, and sphincter function declared to be perfect in 71% and good to excellent in 85%. So pre-op radiation may not increase overall survival, it definitely increases the quality of life of the patient. Leon 1901, where 201 patients were given pre-op radiotherapy and surgery was randomized to either be done at 2 weeks or 6 to 8 weeks. The clinical response rate was 53% in 2 weeks and 71% in 6 to 8 weeks, and PCR was double when surgery was done with 6 to 8 weeks. So there was trend toward increased sphincter sparing surgery when surgery was done after 6 to 8 weeks. So today the standard recommendation is do surgery after 6 weeks and do not go beyond 12 weeks. So if the patient undergone initial surgery, what are the indications for post-op chemoradiation? T1, T2 lesion with margin positive of LBI, T3, T4 not positive, pro-CRM and incomplete resection. So this is the very important trial which compared pre-op chemoradiation with post-op chemoradiation, the German CEO ARO trial. Here pre-op chemoradiation had significant decrease in local failure. That is 6% with pre-op chemoradiation compared to 13% post-op chemoradiation, and acute toxicity was very low in pre-op radiation, 40% compared to 27%, as well as the chronic toxicity. So another important part is in the 194 patients judged by the surgeon to require an APR, a significant increase in sphincter preservation was made, 39%. So, however, there was no difference in overall survival. So, as a conclusion, we can say neoadjuvant chemoradiation and adjuvant chemoradiation has similar survival, but with neoadjuvant chemoradiation there is increased colostomy-free survival, increased local control, and decreased toxicity. So all patients with neoadjuvant chemoradiation before surgery. But the question is, are there any subgroup of patients who may not benefit of neoadjuvant chemoradiation? So in many subgroup analyses, it was shown that in disease of the upper rectum, advantage of neoadjuvant is not as pronounced as in middle or lower rectum. And in very early tumor, where chemoradiation can be totally omitted, neoadjuvant chemoradiation may not be given. So, how do you know if it's upper rectum or lower rectum? I will give you a tip today to the resident. It is not written in any book, so it is not the exam answer. So if you can feel the lower part of the tumor with your finger, so those patients will benefit from the neoadjuvant chemoradiation. However, if you can't feel it, then this patient may go for primary surgery. So for that you need to know how long is your finger. So every surgery resident and oncologist resident should know what exactly their finger uses. So another question is, should patient receiving neoadjuvant therapy should receive adjuvant chemotherapy? So this is a forest plot. I think residents should know how to, this is very bad slide. How to read forest plot. In forest plot, these are all the trials, 21 trials, and this part favors no chemotherapy, and this part favors adjuvant chemotherapy. So only 2 trials, this one and this one, favors no chemotherapy. So all the 19 trials favors chemotherapy. So the recommendation is all patients who underwent neoadjuvant chemoradiation should receive adjuvant chemotherapy with FOLFOX regimen 3 to 4 cycles, irrespective of the pathological report. So if you see the NCCN guideline, in all T3 angio, any Tn plus or T4, the recommendation is to do neoadjuvant chemoradiation. However, primary surgery is done when there is contraindication of combined modalities. So the take-home message for radiation for all the residents is, if it is non-metastatic colon cancer, resectable, resect it. But if it is non-metastatic rectum cancer, do not resect it. Think. Thank you.